Safe childbirth is an issue of human rights. In the 21st century, no one should be dying or incurring serious injury from pregnancy and childbirth.
Everybody knows the causes of maternal mortality, and everybody knows it's a question of preventable death. They are always preventable, because in many ways it's just a question of getting quality of healthcare.
Most women who die in pregnancy die from postpartum hemorrhage or sepsis. Both of these can be easily treated in a medical setting. But many women are either unable to reach hospital or find themselves at facilities that are unequipped.
Women are not dying of diseases that we cannot treat, but they are dying because the societies have not decided that their lives are worth saving.
There have been repeated global commitments to reduce maternal mortality and morbidity, and some progress has been made, but there is still a long way to go.
Yes, it has gone down, but it hasn't gone down for all types of women. So we still have very, very significant differences. If you are an Indigenous woman or a woman living with a disability or a young pregnant woman, from being a woman that is more privileged and lives in the city and is non-Indigenous.
The Committee on the Convention of the Elimination of All Forms of Discrimination Against Women, CEDAW, recognised in 2012 that states have a legal obligation to provide quality maternal health services for all, and that this is part of women's right to equality. How can human rights help in ending maternal mortality and morbidity, and ensuring that everyone can give birth safely? This episode will try to answer that question.
I think right now, locally in New Orleans, we have a lot of traction around the maternal mortality work. So we're working to invest in the city having a statistician around maternal deaths for the city. And so they agreed to do that. So that's a huge win. It sounds small, but it's important. If nobody's counting, then you don't exactly know what's happening, where people are, what's going on. So, yeah.
Gathering data is a crucial first step, as the causes of maternal mortality will vary from place to place.
You must first identify the main cause of your maternal mortality. Here I told you it's postpartum hemorrhage, this issue of unsafe abortion, these issues of sepsis and all that. So then based on your root cause analysis of what is causing your mortality, then it's easy to put mitigations on what will address that specific cause. But generally speaking, the issue is generally equipping the hospitals and making sure that whatever that pregnant woman is can be identified and can reach where they can get help, okay? And then the people giving that help have the skills and the equipment to do it.
At the root of maternal mortality and morbidity are many overlapping factors. The first factor is remoteness. Around the world, individuals are dying in childbirth simply because they cannot access a medical facility. Geographically remote communities often have the highest levels of maternal mortality. Strategic litigation has been a vital tool in connecting these regions to health facilities.
In Mexico, some areas are very, very remote to access. Sometimes a response from the state in cases that we have defended from here, for example, when women have not been able to reach a certain hospital during an emergency because they are living in a remote place and this entails a 10-hour drive or whatever, what the judge establishes is that the state should buy an ambulance or some sort of helicopter.
Human rights law, in particular CEDAW, requires states to take all appropriate measures to ensure everyone enjoys their equal right to healthcare. As this case shows, the courts have the legal authority to order the government to adjust budgets. Litigation is just one way to create transport solutions. Another strategy is advocating for legal and policy change. This advocacy is strongest when the affected populations are empowered to speak for themselves and to demand budgets that fulfill their right to health.
So what communities did in Kakamega, for example, was to push for a program that would really encourage mothers to deliver in the hospitals. And so that county government actually came up with a program that then caters for pregnant mothers who want to deliver. And so this includes ambulances that would carry them right from where they are, the hospital and back. This was an advocacy that was led by women themselves and people in the county. Our work is simply to give them direction, not necessarily tell them do this, but just to direct them and technically guide them.
As well as lack of transport, women are often unable to reach hospitals because male family members control the household resources.
In many situations, women are not able to make a decision on their own. They have to seek permission. A younger boy may decide for an adult woman whether she needs to go to the hospital with an obstructed labor or not. How do we educate the communities to make them know that, yes, these women's lives are important to save?
Dr. Jaldesa has been investigating how to empower women and educate men in geographically remote communities so that maternal healthcare is made a higher priority.
We try to empower the communities, but through education, through taking ownership of the programs, through taking leadership in the healthcare system within their environment.
However, getting women into health facilities is not always the best solution. In places where the health system is dysfunctional or oversaturated, such laws and policies can do more harm than good. This brings us to Factor 2, health system dysfunction.
About 2005, the government of India kind of brought in this policy, which said that budgets would be allocated for cash incentives to get women to come into hospitals for childbirth.
However, since this policy was not matched by an investment in hospital infrastructure, the result was that hospitals were unable to deal with the sudden influx of women.
So this was kind of a misallocation in the sense that budgets need to have been allocated for strengthening the human resources for health, because the public health system was quite dysfunctional, and what was needed was capacity building of health providers. So looking at this, it was clear that the policy had been made not addressing what women themselves might want, but what policymakers thought would be a technocratic solution to solve the problem of maternal mortality. So it didn't begin from where women were, and it didn't look at the reality of the health system itself, but it kind of presumed that if you use the formula of most women in hospital during childbirth, the result was inevitably going to be less maternal mortality.
Cash incentives drove some people to take drastic measures to get to hospital, putting them in a far worse situation than if they had simply stayed at home.
So this is from eastern India, from a tribal area in the state of Orissa. And this is a pregnant woman being carried in a sheet that is strung across a bamboo pole that is being carried by two members of her family. And they're trying to get her to a hospital. So knowing that the government wants women to come into hospitals and that possibly they might get a cash incentive and better services than they are able to access in their village, they have actually carried her on this bamboo pole out of the village, through a forest, through a mountainside, and they're now walking on the road. So when global health systems dictate that the formula for reducing maternal mortality will be to get all women into hospitals, it actually discounts the diverse realities of women, especially poor women, and these are the kind of struggles and challenges that they face when they try to access healthcare.
Mexico faced similar problems, but took a very different route than India.
Most health services are very saturated. And so they're saturated with women that do not necessarily need very specialized care. And so other women that do need emergency care because of different circumstances are sometimes denied services because there's no space for them. And so a very important specific aspect that has been treated by different groups and by the government is around referrals and knowing and to identify situations of emergency that do merit maybe a more specialized care in hospital, and situations that can be resolved in a much simpler medical background.
Advocates in Kenya and other parts of Africa are also trying to put in place referral systems.
You train community health workers, and the community health workers, who can visit every household, and they can know there's a pregnant woman there who needs ABCD. Then the health workers now in the level 1 and level 2 now can facilitate the next transfer to the next level by identifying the risk factors, and then mitigation can be done.
Something that has been very interesting in Mexico has been the incorporation of midwives, specifically traditional midwives that work in communities. Many decades ago, the situation in Mexico would have been complete rejection from the part of the state to traditional midwifery, and basically trying to get all services to the hospitals that are generally in urban environments and that require a lot of effort from communities and families to move there. And so the different trend that we're seeing currently is to recognize the value of these types of relationships and to give midwives sufficient tools to know when to refer maybe women to other types of services, and how to treat just normal pregnancies, which has a very important effect, not only in maternal mortality specifically, but also in much more culturally appropriate services. And these traditional midwives do have the trust of the community. They speak the same language, they know the family. That can be very important to prevent deaths that have not been able to be prevented by the traditional health system. And so rather than rejecting that, some form of communication between these two types of services is very important.
So all this needs money. So if you have the money, you can do it, because the thinking we have, the strategies we have, the paperwork we have done. So it's lobbying from the ward reps, the people who represent the people, the candidates, so that they need to prioritize that budget in their county allocation. And also lobbying the members of parliament, the rights people, everybody, trying to make sure that the voices are heard, that when the budget is being done, that the health is given a priority.
How can governments be held accountable for health system dysfunction and compelled to fund referral systems and quality maternity services? Brazil offers an important case study.
You need to push forward so that it's set as a political priority. And you can do that many ways, through mobilization, by addressing the government, or through litigation. While I was director for Latin America and the Caribbean at the Center for Reproductive Rights, the center created a strategy, a global strategy. Part of the idea of shifting maternal mortality as a medical issue and around medical responsibility to turn it into a human rights issue. So this is where the Aline case happened.
The Center for Reproductive Rights brought strategic litigation on behalf of Aline, who died in childbirth in 2002. Many of the typical problems that result in maternal mortality were present in the case of Aline. Neglect by healthcare providers, long waits for emergency care, and problems finding an ambulance that would transfer her to a higher tier facility. Aline was also a poor Afro-Brazilian woman and was at much higher risk of maternal health problems due to marginalisation and discrimination. This was a human rights issue and was indicative of the kind of treatment many poor Afro-Brazilian women face when trying to access maternal health services. It was brought before an international human rights treaty body, the CEDAW Committee.
And in 2012, the CEDAW Committee handed in this decision, which for the first time recognized maternal mortality as a human rights issue. And it also recognized that this was a violation of women's right to equality. So this was really mind-blowing at that point, because it changed the landscape. While there were resolutions at the UN level saying maternal mortality is this issue, there wasn't any palpable case. There were numbers, many numbers, saying this is an issue not just in Brazil, but in Latin America, in Africa, in many places. But this was the first time that that CEDAW said, Brazil, you are accountable for this, and you should have changed. You should have oversaw your private health system. You should have had guidelines that were in line with human rights, and this is a form of discrimination that needs to be changed. That needed to be translated into political commitments. And the way of doing that was first to getting the word out. So it was a question of partnering with many organizations, local organizations in Brazil, and starting to spread the word of the importance of this, because the decision was not only addressing maternal mortality, but also a question of intersectionality and the right to maternal care of Afro-Brazilian women. And with time, there was a whole strategy also on implementation. So first, there were different negotiations with the Brazilian government. The final agreement was set forth, including individual reparations for the mother of Aline and also symbolic reparations. And this really made a change, because it was a moment where the government said, okay, we did something that was wrong, we are responsible. And in Rio de Janeiro, there were symbolic reparations, a plaque that said, this is in memoriam of Aline, what happened was wrong. And that became a very powerful narrative.
But when Dr. Creer Perry looked into data on maternal mortality in the US, there was another important issue. Factor 3 is racism.
Despite income or education, Black women were 4 times more likely to die in childbirth in the United States than their white counterparts. Here in the UK, it's 5 times more likely to die in childbirth. It's not anything genetically different or nothing about our biology, but how we're treated, how we're seen, how we're valued. We have studies that show that physicians in the United States believe that Black people, Black women, don't feel pain the same way. And it comes from a history of us doing experiments on enslaved Black women without anesthesia, and they were able to tolerate those surgeries. So the textbook said, Black women don't feel pain. And so that's what we're still teaching, right? So how that manifests itself, think about this. One of the leading reasons that we die after childbirth is heart attack, okay? So if I come to the hospital and say I'm having chest pain, you're not gonna evaluate my pain because you don't think I really have pain. And you think I'm asking for pain medicine or drug seeking or all those other things. And I also have internalized myself that I'm not supposed to be too loud or take up too much room or make you nervous. So I'm gonna say I have pain, but I'm gonna say it really calmly. So you don't see, I'm not even projecting to you that I'm in a lot of pain because I've taught myself how not to be too much of a bother, right? Another reason that Black women die in childbirth is from hemorrhage. So if I say I'm bleeding so much, it's soaking through the floor, it's everywhere. If you think that I'm prone to not telling truths, if you don't believe my story and my history and how I'm explaining it to you, you're less likely to evaluate that.
When racism is the cause of maternal mortality, one solution is to work with healthcare providers and help them to understand how bias might be affecting the outcomes of their patients.
So a lot of my work is debunking myths. There's a belief, in fact, I had the belief myself, that the reason that we have differences in outcomes or inequities in health outcomes is because there was a biological difference between people based upon race. That's what we were taught in school, that's what we were trained to believe. And so the good news is we finished the Human Genome Project and there is no genetic basis of race. So what are the reasons? Why do we have differences in outcomes based upon people's skin color, right? So my job is to really have those conversations. So I do it either on one-on-one like this, or also with large audiences, doing trainings for 2 days at hospital systems and also at public health departments. There are usually people in the room from front desk staff, if you're a nurse, because it matters the bias when you answer the phone, as well as nursing staff, hospital administration, physicians, midwifery. And we start off really with just some truths, right? Because I said, most of them, when I say that race is not genetic, a lot of people don't know that. And why that's such a critical point is because if you get stuck there, if you believe that there is a biological reason for differences, then you say, well, I can't do anything about that. So that's why we spend a lot of time with the training, really having some truths around that and how the idea of race was created. We do some role playing with folks around what implicit bias looks like, all right, and how we all have it. And then what can we do to be mindful of our bias and to work through our bias. And then we spend some time really thinking about what we could do next. Like now that we understand this kind of history, we understand bias, we understand power and authority, and how the patients are dynamic around power and authority, then how are we going to do it differently? What are we going to do as a system, as a hospital, as a public health department, to make sure that our patients live their best lives? Yeah.
Problems in facilities, especially for women of colour, can even extend to verbal and physical abuse. Factor 4 is obstetric violence. Shockingly, healthcare workers have been known to insult, slap, and assault women who are delivering.
There is a kind of disrespect and abuse that's become entirely normalized amongst those providing childbirth care. And this is often not talked about, but it's very visible, especially for poor women or women from, in India, the lower castes.
So you come to the facility, health facility, and then you find burned out health workers, because the numbers are huge and they're very demotivated, And so they kind of are very rude to people coming to deliver. Some people even beat them up, to deliver in some rural places,
Healthcare professionals are much more likely to be violent towards their patients when they are stressed, overworked, and receiving low pay. Individual accountability should not be forgotten, but obstetric violence is a symptom of broader structural issues in the healthcare system.
Some facilities are trying to have the places which can help the nurses, counsel them, when they are burnt out, and also just employing more health workers, motivating them, might reduce the burnout and they might be kinder to the patients. But again, if you have a working referral system, might also reduce the violence we see at the facilities.
So the concept of obstetric violence has been framed as a human rights issue and as a type of gender-based violence, which we have found very useful in Mexico. But at the same time, it poses some challenges. And I think one of the main challenges that we have faced on this issue has been the tendency, at least in Mexico, to try to resort to punitive measures when speaking about violence. Sometimes speaking about this as a type of violence leads to resorting exclusively to criminal law. It does alienate health professionals from the discussion. The type of situations involved in obstetric violence can be very ambiguous or very varied, and most of the times they're due to very systemic circumstances related to budget allocation, to infrastructure, to medical education in general. Another aspect that I think is very important in this work is engaging with health professionals, actually sitting down with health professionals to understand what they are lacking and trying to separate from these perspectives that completely individualize the problems and, I guess, point fingers at specific individual health professionals for their lack or for negligence or situations like that.
Forming collectives of women is another way to reduce obstetric violence and can empower women to demand their rights to freedom from violence and assault.
In the area where I have been working, we've tried very hard to ensure a shift in the power relations. So women in those areas have been organized into collectives. They are informed about what are the standards of care, for example, in pregnancy checkups, in childbirth services, in postpartum or abortion care. And being informed, they're actually able to negotiate with the providers, demanding and kind of putting the pressure of their collective, saying that we are a collective and if you don't provide us with the required services, we could take this up with the higher authorities. And these women have been presenting their kind of field level monitoring findings to health officials. The good thing is that in these very local kind of situations, health officials have been moved enough to feel answerable. For instance, they've given their cell phone numbers to these women leaders and said that, if anybody harasses you, for example, or doesn't provide care, you could just call me on my cell phone and I would, take care of it. So in these really small pockets where the women that we've worked with, where they try to seek care or their family members or others in their community try to seek care, they've been able to make a change. And so I think that's really the way to go, that we do need to empower the users of services, in this case the rights holders, with complete information about their entitlements and about the standards of quality that they should be expecting in public services.
Empowering women is a common thread that runs through all these issues. It can make a huge difference if women know and understand their rights when they're interacting with the healthcare system, local governance, and even their own families.
I think that women understanding that maternal care and quality of care is a right can can be huge. It has a huge potential because it's a starting point for women demanding in hospitals and saying, okay, this is not normal. I should not be subject to this kind of treatment. I have the right to. Demanding is a starting point to changing many things, and it starts with knowing what's the right that you have.
Rights are a process of negotiation. So we do need to work a lot with the rights holders, and which is why I feel that often we get so caught up in ensuring the normative standards through all our advocacy at international forums and through our cases, the litigation strategies that we adopt. We forget about what happens in the actual transaction of rights, which happen through material means, for example, access to services or access to grievance redress. And there the power asymmetries are so steep. I think unless we work with the rights holders, we cannot bring about lasting change.
There's a long way to go to ensure that everyone can give birth safely. But by understanding the causes of maternal mortality, advocating for legal and policy change, litigating, and empowering women, we can make important progress towards this goal.
This was the day where the plaque at the hospital where Aline died was unveiled. And Aline's mother, who's also there, it was really powerful to really have a plaque that says that that's in memoriam of her daughter. So it felt like it was really a moment of change.